Okay, we have 26 people have already come in. So nice. We had well over 100 people sign up. There may even be 200. Generally, we've had 90 to 110 or so people attend. So happy we get an opportunity to do these. So people are able to enable closed captioning if they want to, so they don't have to listen, they can read. That's great. And now we have almost 40. Give a couple minutes here. We'll give 3 or 4 minutes for people to come in, and then I'll do a little brief introduction, and then we'll begin our seminar. For those of you who are here, thank you. And remember that this will be recorded and placed onto a site for viewing post clinic, as well as included now in our all access misophonia video line of films and documents that have recorded and memorialized our progress since 2013. So it's a wonderful way to learn everything that we know. If you want to make time to join that organization, please go to our website at misophonia-association.org. And for about less than $10 a month, you can be part of a large group of people who can access those videos and films and convention recordings. So we're up to about 43. That's very nice. On a Saturday morning, it's 3 minutes. We'll start the session here in about 1 more minute, and then people will just keep joining, no doubt. Feel free to ask questions in the Q&A, or I'm not sure if it's the chat. It might be the chat. And then we'll be fielding those, and Dr. Jaffe is always checking some of those too for any additional things that come up. We appreciate all the questions you sent in to begin. Coming up, okay, good. And I think we'll go ahead and give ourselves a start. Good morning. I'm Marsha Johnson here in Portland, Oregon. I'm very happy to represent the Misophonia Association today, an organization that's dedicated to the education, advocacy, research, and support for misophonia wherever we can find it. And we've been in this striving for over 10 years now, and it has been the most wonderful work, and we've had the best experiences together. And today we're going to have another one. We had an idea a few years ago, along with our annual convention, which this year will be in Atlanta, Georgia, probably in October or November. We're still picking out that final date. And we came up with the idea to offer free misophonia clinics. And we try to do 3 clinics a year. And these are open to everyone to come and hear from the top professionals in our field about interesting subjects. So please remember our housekeeping rules. I think in the webinar setting, you can't come on the screens and do things, but the presenters too will be very cautious about any eating or drinking and trying to control the situation so that everybody can participate comfortably. So thank you for coming, and we appreciate your donations to our organization. By the way, recently we received $2,500 and $1,000, and those little contributions go a huge way in helping us continue our mission. I'd like to introduce Dr. Jaelline Jaffe, who will introduce our speaker today and herself. And thank you so much again for coming.
Okay, thank you, Marsha. All right. So good morning. Blank screen to me at the moment. And Dr. Webb, the Misophonia Association has in its midst one psychiatrist, and that is the person that we're meeting with today. Dr. Webb is located in Colorado and has participated in our conventions recently and is doing a lot of different interesting things on behalf of the Misophonia community. The main reason that people were interested in having him as part of these clinics today is regarding questions about medications and experiments to see what kinds of medications, clinical trials, what kinds of things might be most helpful to people who are dealing with misophonia. So you folks that are on the call here sent in questions. I have grouped all those questions so that I can address them kind of in batches, because we're not going to have time. We only have about an hour, and that's not enough time to go through all the questions. So I'm going to be directing many questions to Dr. Webb, who will introduce himself in just a moment, but I'm going to direct questions to him in groupings. And there are also some questions that I might address. So my part in the misophonia community, I'm a psychotherapist. I'm in Southern California. I work with people all over the world and have been doing so for a dozen years or more in the misophonia community. And so some of these questions are right up my alley, and many of them are specifically targeted toward Dr. Webb. So would you like to introduce yourself?
Yes, after unmuting, I would love to. Well, thank you, Dr. Jaffe. Appreciate the intro, and always good to be among friends, even on a Saturday morning. You know, if you keep coming back for more, it must be good, and it is. This is a really thoughtful community, and really appreciate certainly you and Marsha's efforts to keep these things going. It is a lot harder just to keep simple things like regular meetings going than one might think, at least me. But yeah, happy to be here and excited to talk through some of these questions. Sounds like you might have a good order to send them to me, and I'd be happy to jump right in.
Okay, so for those of you watching, we will take ourselves off screen and off sound if we are going to do anything that will be distracting, and then we'll pop back in. I am going to be looking that way periodically because I have the questions over there on a separate screen. And so that is where my motion will be directed. There were a number of questions about medication in general, and then about some specific medications. So let's start with medications in general. People who go to their primary care doctor or therapist or audiologist, they're not going to get medications they're not going to get information or medications that are going to be necessarily the right thing, or maybe aren't the most useful, or they may not have heard of misophonia in the first place. So that's one of the reasons we're so grateful to have a psychiatrist on board with us. So one question about medications is whether they're safe for teenagers. And if so, what medications have you come across that may be useful for misophonia and that would be able to be used by teenagers?
Yeah, that's a good question. I think it's important to remember that as of now, and at least probably for the next few years, there aren't medications only for misophonia that are specific for that. What it really is using medications already being used for things that have similarities to misophonia. So medications already used to treat anxiety, intrusive, unwanted thoughts, strong body reactions to unwanted stimuli, sounds, sights, things like that. So the safety of medications really is the same discussion one could ask about the safety of these medicines for treating any other common mental health concern. So how safe is it for teenagers to take medicine to treat anxiety, for instance? And that itself is a good debate. That's its own big subject. Safety is a relative term that has to be asked in the context of why you're doing it in the first place. If you are taking an antibiotic for a sore throat, there is a risk to that. Antibiotics can have very serious side effects sometimes. They have all kinds of potential problems. So it would be, of course, foolish just to take it because, I don't know, you just felt like it. But if you're taking it to solve a problem that is likely to be much more harmful than the antibiotic, it's worth it. And so I think the framing always has to be a good understanding of the problem you're trying to tackle and accurately understanding if that problem is serious enough to be worth the risk of taking a medicine. I think there's a subtext embedded there of being fooled into doing something you shouldn't have been doing. I think that's the subtext is, was I talked into something? Did clever marketers or companies sell me a product that I really probably shouldn't have been using? I think that's a valid thing to consider. That's also a different subtopic, is to think about how well we understand the safety and efficacy of these treatments. Do we really know what we're getting ourselves into when we take one of these? That's probably a good umbrella subject for all kinds of questions that I'd be happy to jump into. But I think that's the framing. The medicines that we have are the ones we already know about for treating anxious related problems. And it's a question of whether the cost of the medicine outweighs the damage being caused by the illness.
By that, you mean the cost of using the medicine?
Cost of using, yes.
Yes.
Yeah. Saturdayisms, they require some interpretation at times, yes.
Well, you're relying on somebody who doesn't do mornings, so, between the two of us, it makes
That's
sense.
right, yeah. Who knows what we'll say, yeah.
All right, so another general theme has to do with other related conditions, just as you're bringing up. So we all know there is no such thing as misophonia if what you're relying upon is a code book. There is no misophonia listed in the ICD, which is the medical code book, or the DSM, which is the psychological code book. It isn't there yet. It will be. It just hasn't gotten there yet because I think they don't know exactly where to put it. And in part, that is because it has so many common features to some of the other things like you were just alluding to. Probably why one of the most common medications that people get prescribed have to do with anxiety, being a high component that goes along with misophonia. So one question has to do with other co-occurring disorders like ASD, autism spectrum disorder. Are there medications that would be useful or perhaps not because somebody is on the spectrum?
That's the global difficulty of understanding and treating mental health concerns, is that they overlap so much. A lot of my day as a psychiatrist is disentangling someone who may come to us believing that they have a certain condition and finding out that they mostly do, but that they may have another condition or what we call a different problem that better explains it. It's rare to have a totally textbook perfect condition that follows only the criteria that that condition is supposed to have. And then, well, actually a better way to say it is it would be very difficult to be able to classify misophonia as this totally independent condition that has symptoms only it has that no other condition might also kind of have. For instance, being annoyed by certain sounds is very common in being generally stressed out, having a more anxious personality, having different problems even within your hearing system itself. There's all kinds of other problems that can lead to not liking certain noises, or having a strong reaction to certain people's behavior could relate to having had a traumatic experience before with something that looked like that. So it's kind of a bunch of like Venn diagrams that overlap 80% of the way, and you have to look at the edges of them, the things that are unique about them, to try to pick them apart. For treatment, there's a blessing and a curse to this, that the treatments we give for things that look alike are often the same. There's broad spectrum. If you are generally easily bothered by something, whatever the reason that is, whether it relates to you having autistic traits or having obsessive compulsive traits, the treatments are often very similar still. That reflects that our technology is not very sophisticated here yet. In 10 to 20 years, we probably will have very individualized specific treatments, and wonder how we all lived like this. Like, how did we live in a world where we just sort of dropped these non-specific things and hoped they worked? But that's where we're at still in 2024.
Okay, so misophonia, for anybody who doesn't know, which I don't think most people in this call fall into that category, it was only named a little over 20 years ago. So the research is, in its infancy, sort of, and it'll take a while for it to catch up, to have a much better understanding of the problem. And as you're pointing out, there are a number of co-occurring or similar disorders. So it's something to pick it apart and then figure out what's the best way to approach it. And back to the question about teenagers or even children, because it's so non-specific yet about what the right approach is, what dosage, what particular medication, it's an experiment, and no parent wants to be experimenting on their child. Well, let's try this particular brand and this particular dosage and see if that helps. Oh, it doesn't. Let's try a different one. It's not yet a very refined science, and I'm sure, as you're saying, it will be much better. And right now, parents are in that uncomfortable situation of trying to figure out what should they do to help their kids. One question that has come up in recent times, especially since the last Misophonia convention, where you were talking about newer ways of considering this medications. Some people would like to know what medications you are doing trials with, and how do their kids or themselves participate in those trials, if such things should be.
Excellent. You rightly pointed out, this is still very much in a early phase of, I would say, informed experimentation. Experimentation can have different meanings depending on how you hear it and your background. It can imply something kind of dangerous and reckless and unknown, whereas in another context, it may just be a precise way of saying, we haven't proven beyond all doubt that this is only the right way to do this, and that there's some uncertainty to it. I would say 5 years ago, medications were totally unknown as they related to misophonia. If you looked it up online, if you talked to anybody, nobody had any idea what medicines might even help this. There just wasn't a way of thinking of connecting those. And so it really would have been kind of a blind stumbling about, kind of hoping you got something right. I'd say we're currently at a state of having some informed approach by seeing some cases where it seems to work, and by analogy to other illnesses that have similar mechanisms. Meaning, we have some good information to know how to help people whose nervous system, sympathetic nervous system, becomes very activated, a fight or flight response, when they don't want it to be. That especially is true of trauma, someone who's had a traumatic experience and they either think of that experience or they see something that reminds them of it, and their autonomic nervous system becomes very activated. It's very uncomfortable. They have a panic fight or flight response. It's very unpleasant. We do know of ways to help calm that down. That's one type of medication approach we think we see some success with and are very interested in studying more rigorously. So that again is things like propranolol, the beta blockers that calm your body's surge, its response to adrenaline when it's activated by a trigger. We also know that many mental health concerns related to panic or anxiety can be calmed down with certain medicines like anxiolytics and antidepressants. For a lot of people, taking those appropriately, which is the key, if you're done right, it can reduce one's immediate anxious response to those triggers. And we think we see some evidence of that also in misophonia, where taking these things sometimes can calm your brain's assessment of an anxious or negative trigger and make it not hurt so much or not seem so threatening. So that's hearing myself talk like that, it sounds very vague, like I'm giving some intro to some class where we're going to need a long time to pick apart what that means. I guess compressed down, we have medicines that we know analogously help with a lot of the symptoms that happen in misophonia. And we think that does help sometimes. We see that. But the science is not at the point where you can really check it off and say, proven beyond doubt, we know this is definitely the right thing. So it's kind of an uncomfortable middle. However, it is light years better than it was a few years ago, where there really was nothing at all.
So going on to specific medications, that some of which you have alluded to, a number of the questions that people asked about were specific medications. Fluoxetine, guanfacine, magnesium, Zoloft, Wellbutrin, naturopathic treatments. Do you want to address any of those in particular?
Sure, you bet. You'll see me a lot hesitate and choose my words carefully when I talk about these things, because the backstory to that is it probably reflects my own personality, maybe the way I was trained, but I'm very against telemarketing approaches to things. There is much opportunity for exploitation when you find people who are hurting and desperate for answers. That's a setup for people to come in and say certain things to get people to follow and get people to do things. That's how infomercials work. Find people, that's why you do it at night to populations that are often tired, maybe even related to things related to illness or not feeling well, and that's the time to strike. I think that's very dangerous. We do not want to start our field off as being the ones that figured out how to take advantage of a difficult situation. Therefore, we should choose our words carefully. It is risky to tell stories. Humans like stories. I do as well. We like to hear stories about the person that did really well when they tried a treatment. That's how a lot of advertisements work. Someone gives a testimonial. They say, I did this one diet, I took this one pill, and it changed my life forever. It would be very not right for me to tell stories about people that did well with certain medicines with any implication that that's probably you if you would just sign up and do it. That's why you see a lot of hesitation in the way I explain these things. But that also has to be balanced with the reality that people do sometimes find healing through these treatments. I would say, like with psychotherapy, there are a lot of people who have come to us and said, therapy didn't work for me at all. Yet I know Dr. Jaffe has helped a lot of people substantially change their lives. It can work. It just isn't guaranteed for any one person. For medicines, you listed some of them, like fluoxetine, an antidepressant. That has been around for decades. It has a well-established safety and use profile for anxiety, depression, obsessive compulsive disorder, and even for trauma. It can be very useful for those conditions. And it does seem to help sometimes, best we can tell, with things that look like misophonia, people who are become very upset, very panicked, anxious in response to triggering events. I think that one has a good chance of being useful. It needs to be thoroughly tested to make sure we really know we're seeing that and not a placebo effect or something that looks like it. But I think it has a good shot of it. It also is generic, cheap, it's affordable, and very easy for the community to access and be able to give that. We just need to sort of work out how to responsibly do that and make sure you can also measure progress as a patient. One of the things the difficulty in saying whether a medicine, quote, works for misophonia is that a lot of these medicines take time. They don't usually work the first time you take them. There isn't a dramatic curtains being pulled back and your life is suddenly better, which is very frustrating a lot of times. It can take weeks, months to start to see a difference in symptoms. And to make it even more complicated, often you need to try a couple of different ones because of side effects or because it just doesn't seem to be working well enough. So the reality is, treating misophonia in 2024 often means trying a couple of different medicines that we think by analogy might help with the symptoms, and being really good about regularly measuring the response and encouraging the patient to keep going, even when those weeks and weeks of waiting can seem like a long time. I think that's the real challenge. When someone is feeling desperately awful, you're really kind of hoping to finally have the thing come in and save you, to take the thing that finally the sunlight bursts through and you see a way out. It's a lot more difficult when it's going to be a hike, many weeks long, to sort of grind up the mountain to get out of those symptoms. And it might mean you get 50% of the way out. I see a lot of times what looks like definite improvement in symptoms, but not 100%. I'd say it's more common that you aren't 100% cured. You're just better than you were. And that takes a lot of patience and support from the community to sort of remind you that that's much better than it used to be. We just need to stay patient, even because the symptoms are still there a bit. So it's a very roundabout answer to those medicines. Now, fluoxetine was one you mentioned. That is one that I think probably is going to have some use. There's at least one published case report of this appearing to be quite effective. And we've seen instances, most commonly what I see is that it will seem to reduce symptoms, maybe by half or so, something like that. So it does seem to be useful, but not a magic cure yet. You mentioned some others. Could you remind me the next one?
Quanfacine, Zoloft, Wellbutrin, magnesium.
If we're grouping, Zoloft, sertraline is very similar to fluoxetine. They're both antidepressants with a very similar mechanism. So kind of the same answer there. Wellbutrin is a different kind of antidepressant. It does not appear to work on the serotonin system particularly, for instance, and is not typically as effective for anxiety, but can be effective for low mood, low energy, depressive states, and sometimes can help people seem to focus a bit better. It's used off-label occasionally for ADHD. I've seen definite what appears to be definite benefit from the SSRIs like fluoxetine, sertraline, Zoloft, Lexapro, i.e. escitalopram. Wellbutrin is a wild card. It reminds me of ADHD medicines like Adderall or Ritalin. Some people seem to think it helps them, that taking something that helps with their focus, especially if they have ADHD, may quiet the noise in one's mind a bit and help the triggers be more manageable. But I've also seen other cases where it seems to make it worse. So it's kind of a coin flip of whether it may help you or actually make it worse. You also mentioned guanfacine. Guanfacine is a different type of medicine. Guanfacine is closer to the beta blockers than propranolol in that it tends to reduce one's surge of fight or flight response. It has a calming effect. It's often very useful in people who feel very impulsive. They sort of act before they think or become much more angry than they would like to. So people with a very flashing, fast temper sometimes find that this calms that down a bit. I think by analogy, it does seem to help people sometimes with misophonia, especially if one has a fast, angry response to a trigger. By analogy, there's a shot that this may also calm that down. This is observational, very much observational and not proven science, but my observation so far is that the medicines that calm one's body down, like beta blockers, propranolol, and guanfacine, tend to have a feeling in patients like they'll almost describe that in their mind, they're still as annoyed by the triggers they were before, but it doesn't hurt like it used to. Their body doesn't run away with them. Their heart rate doesn't jump. They don't feel their muscles clench the same way. They don't have this overwhelming sense of anger or panic like they used to. So it becomes this curious sort of cerebral, I still find you really annoying, but oh well. I think that's a really interesting insight that if it really holds true, probably opens the door for really good psychotherapeutic breakthroughs. I think that's one where you really need a good psychotherapist, hint, hint, in tandem with you as you work on that, because if one's body can stay safe and can feel solid, but your mind is still annoyed with something, that may leave an opening to work on that, to do those cognitive exercises, to say, well, if it's safe and okay, do you need to be annoyed by it? Maybe you could let that go. Because I think one of the traps of misophonia, untreated, is that when you're triggered by something, having someone tell you you should just get over it is so, what's the word, frustrating, but that's not a good enough word. Because to the misophone, at least, most that I know, it's not just a matter of being annoyed, it's that you feel physically assaulted by it. Your body is very unsafe. It's very in pain or very, very activated by a trigger. And so it almost sounds more like if someone comes up and physically slaps you across the face, you should just get over it because no one else is bothered by that. What a silly thing to say. It hurts. There's no stopping that. But a possible opening, something we're very interested in, is whether you can, I've described it almost like put one of those big foam pads, like the big sports foam pads or something, on the hand of the person slapping you. So you still know that they hit you, but it didn't really hurt. It's just kind of annoying. And maybe that creates an opening where you can walk back from the trigger and not be as terrified by it.
Well,
Yeah.
go ahead.
No, go ahead.
One of the things that you're alluding to, and I think is totally the way to go, really, is a multidisciplinary approach. I think this condition started out with audiologists because people were experiencing a reaction to a sound. So it was thought like, well, there's something going on with the hearing mechanism. And we now know, at least we think it's much more neurological. The research has indicated that is neurological, but it also involves audiology components. And it also involves a lot of emotional components and family relationships and things like that. So it's a complicated picture. And I think that's why a multidisciplinary approach is probably the best way to go. So you get some medication and assistance in direction from somebody like a psychiatrist, like Jadon, Dr. Webb. We also can get some help from audiologists like Dr. Johnson, who started all of this by naming it 4S, selective sound sensitivity syndrome, before it got cutely named misophonia, which is not really an accurate naming, but in any case, audiologists can help by providing sound generating devices that help the body begin to acclimate and calm itself down. And then psychotherapy can help somebody learn how to manage their emotional reactivity and calm themselves down and look at things differently. There's also one of the things you mentioned earlier, something along the lines of trauma. We don't know what is traumatic to somebody in particular. So trauma, everybody knows that if you were in a major car accident or somebody held you up at gunpoint or something, but there are little traumas, lowercase t traumas that happen to people all the time. And when you're a parent, you don't know what those have been with your child. You may not have seen it, or you may have seen it and you didn't interpret it that way. So there may have been things that your child experienced as traumatic that you wouldn't have called traumatic, and therefore you wouldn't understand why they're having this particular reaction to something that doesn't look like anything to someone else, but it does to that child. So it may be that there's trauma underneath a lot of this, and we just don't know what it is. And sometimes traumatic events happen and they are affecting the person at a level where they don't really consciously access it. It's not something they can remember exactly. It's something that maybe happened when they were much younger and they didn't have much language to explain it. So there's all kinds of complicated overlays that lead to why is it a good idea to have a number of people involved in treatment. One of the questions that was asked was, what do you say to people when you're told to block it out? That's like the example you just gave. I say to people, well, if I tell you, don't think of a pink elephant, that's not how our brains don't process like that. So if somebody tells you, well, just don't pay attention to it, it does not help. And in fact, it maybe makes it right in the front of your mind now. It makes it even worse. So much better would be for people to learn ways to put their attention on something that's more interesting than that awful noise that's driving them crazy.
Yeah, that's right. Yeah, stop paying attention to someone slapping you in the face. It's fine.
All right, now there were some questions about visual triggers. So misophonia literally means hatred of sound, and we know that that isn't true in the first place, but that doesn't account for visual things, which now a lot of people refer to as misokinesia. Can you address some of that in terms of what you've seen and what you do about that?
Absolutely. Yeah, I do think, I use the name misophonia myself, but I do think it's inaccurate and has an absolutely unintentional sort of gaslighting component to it of hatred of sound also involves all the other senses. Okay, to anyone that sort of follows logical sequencing, that's kind of hard to digest. And in fact, really is a problem for a lot of people who will, even patients that we have, will come in and say, well, I keep hearing about misophonia, but a lot of my triggers are just seeing people do things. What does that mean? It sure seems to me that this is more about a reaction to something in the environment that takes on a strong threatening vibe to it. And just as with PTSD, with trauma, one can have flashbacks and be triggered by seeing something, hearing it, smelling it, And I think the same is true here. That at the last convention, we sort of threw out this idea of renaming even like something like misosensorium, the idea of this encompassing strong aversive response to any kind of sensory stimuli that most people might not find threatening. That's probably a better way to think of it, but lots of debate and things to be worked out. Visual triggers are certainly a serious problem for a lot of people, probably almost as much as auditory triggers, according to some of the most recent surveys. Like, it's very common. And in some ways, it can be more difficult to address environmentally because you can at least wear earplugs or have a good sound generating device, but it's hard if someone's in your visual range and kind of has to be, like for a class or you're driving or something, and they're doing a trigger. It's hard to blind that. So it's definitely a serious concern. We've had other people very credibly report misophonic-like responses. Haha, use the word misophonic to like movement, even a sense of like if they feel the floor moving, that can be a trigger. And the common pathway still seems to be that strong fight or flight reaction to a highly negative emotional experience. And my guess is that the treatments will be very similar, that the medications will probably be pretty much indistinguishable. Doesn't really matter what sensory input you're getting. The idea is you're having that big, strong negative response. Although, was there another question in there that I missed? Uh-oh, I think you're on mute.
Okay,
Aha.
I hit a button and it made all sorts of things go crazy on my screen. And yeah, I think you addressed that, visual things about visual. Yes, there is such a thing, and not just visual, but many other sensations, as you were pointing out. So people would often ask questions about specific types of treatment and what's recommended. And, how one of the big things is, how do we work with younger children? I don't know if you have younger children coming into your neck of the woods. I do in my world. So there's a question about a 10-year-old coping without exploding and being aggressive, 11-year-old managing his anger around his brother, the sounds his brother makes, middle school students struggling with verbal harassment. Do you have any of that age that you see, and what do you do with them?
Absolutely. We've seen, boy, all ages, even down to I think like age 5. It is a problem that strikes young kids right at a really bad time developmentally, right as you're trying to develop your own sense of who you are, how you relate to your family, often in those preteen years where you're trying to also mentally grow up and individuate, separate a bit from your family and become your own person. That's a pretty awful time for this thing to strike that makes it feel as if you're being constantly assaulted in your own family. That's or in your school, your day job where you're supposed to be all day, that's the place it picks to continually strike you, is a pretty awful thing. I think there's going to be, especially as it becomes acceptable to talk about this and becomes unacceptable to bully people because of it, I think then we're going to have a bit of a national reckoning, a bit of, wow, geez, we humans always think we're so morally upstanding. Each generation thinks it finally got it right. And yet we were just as awful as the people that used to make fun of people on the autism spectrum, just because we didn't know what else. We thought it was okay to just make fun of people who are different. And here we are doing the same thing now. It there's a reckoning coming to recognize that this is quite an awful thing that has this pernicious, this evil way of sort of striking right at bad developmentally inappropriate times. And in ways that kind of convince the victim to shut up and deal with it. So there's a lot more that needs to be said and understood about this. But I think also there's a sense of, we almost can't talk about it too much because it's so awful. It's almost best to just kind of try to get over it and walk past it. Like if something is so awful, you almost have to just kind of ignore it just so life can carry on. Because what else are you supposed to do about it? So you recognize it, even as a parent, a sibling, a friend, what do you do with suddenly recognizing that something about you that you do every day constantly fundamentally assaults someone you care about? How do you live with that? That's almost too awful to bear. And so you almost have to displace that and go, whatever. Everybody gets annoyed. It's how life is. But I think when we develop treatments good enough to really take it out, it'll provide safety to now kind of own up to it. To go, yeah, how awful to think that I hurt the person I cared the most about and had no way to stop it and certainly didn't mean to. But at least now we can do something about it.
Well, I think you're touching on a subject that I encounter a lot, which is, and you used the word that I use, which is bullying. If someone in the family, for example, we'll talk about a school in just a second, but if someone in the family doesn't understand what's going on and they think you're just being, this kid is being manipulative, they're being bratty, they just want attention, it isn't really a problem and that sort of thing. If that's what people think, they don't treat it as a serious situation to be respectful and so forth. So there's that side of it is a lack of information. The other side of it is, like, I think if you keep doing something to someone who has told you that it's hurting them and you keep doing it anyway, that's bullying. And that is very mean. I think if you tickle a baby or even somebody else, you tickle them and at first they're laughing because it's fun. And then they get to a point where they say, stop. If you don't stop, you're teaching that person that their word stop doesn't count. Do you want to be raising a child who goes out into the world and doesn't feel like they have the right to say stop when something is hurtful to them? Do you want to raise children who go out and push somebody else's boundaries when that other person has said stop? That hurts. So that is not the kind of parenting we want to be, promulgating here. So I think bullying is the correct name for that. And in middle school, I think it's the worst because kids in general are more accepting of each other when they're younger, and they're more accepting of each other usually when they're older. But in that middle state, when they're trying to figure out, as you mentioned earlier on, when they're trying to figure out who they are and differentiate themselves from everybody else, it's a nasty period of time. And kids do tend to be mean to each other. So I run into, should I tell people at school that I have this condition? I don't want to tell them because if I tell them, they'll use it against me. I think in middle school, that is actually a realistic concern. In high school, much less so. In elementary school, it depends, it depends on the kids you're hanging out with. Are the kids in your classroom coming from an environment where they feel loved and supported in their own family and they don't turn around and pick on somebody? Or maybe they're having issues in their own family and they find somebody else to be a target. So it's a complicated issue like any kind of bullying is. I think we need to educate the schools so that they can see it that way and they can step in just as they ought to step in for other kinds of bullying.
Love it. Brilliant. Spot on. And I was even thinking as you said that there's also, I guess you could almost call it like the pain of accommodation, where the ones that do go, oh, wow, I didn't know that my breathing was so offensive to you. Ugh. And in, say, high school, what a thing if people that care about you or just have to sit next to you even kind of go, oh, wait, no, that's the one that doesn't like it when you do that thing. and you become the special one that everyone kind of whispers about and goes, oh yeah, he's the weird one that like will get on, he like freaks out if you breathe. Try not to do that, I guess, or something, you know. So even these well-meaning attempts to sort of accommodate are a very unwanted isolative feeling for the person suffering, to go, oh good, I'm glad I'm such a weirdo that I have to like have everybody whisper about me and try to avoid doing things around me. So it's like hard to win in that environment.
Yeah, I sometimes make a comparison to allergies. Misophonia is not an allergic reaction to sound, but it's a good way to explain it to somebody who doesn't understand it. So I will say to, let's say in a family where maybe the parents have different ideas, one parent says, we need to make accommodations for this child. We know they need some assistance with this. And the other parent says, no, that's not a good idea because they have to learn how to deal with the world. And we need to be teaching them how to manage around these things. And we shouldn't go easy on them. That's not going to help them. You have these two different ideas. And I sometimes will say, well, if your child had a peanut allergy, the kind that sends children to, or adults even, to the emergency room because their throat closes down, they can't breathe. If you knew they had that peanut allergy, would you be eating peanuts in front of them or around them? Would you be having candy bars that have peanuts in them? If that would cause that kind of reaction, would you do that? And if you would, frankly, I think you're being an abusive parent. I mean, that would be really cruel and dangerous to your child. Think of it that way. If you find out that this sound, whatever this sound is affecting your child in that way, or anybody else in your family, are you going to continue to do that and not make that accommodation? I mean, we have classrooms now where peanuts are not allowed. Why? Because they're children who have peanut allergies. So we've gotten the school to understand that and be accommodating to things like that because they understand it better. We need to get more people on board with understanding what the deal is so that they can behave more appropriately and not be resentful about it.
You know, it's interesting hearing you say that, how it almost sounds like that what I imagine a lot of the books of manners were written about. There's a lot of attention, if you look at those 1800s manners rule books, how one should eat at a table, which looks awfully similar to how a lot of people might prefer that if they were triggered. So you wonder how many of those authors may have had similar conditions. And misophonia has this curious way of just not appearing. People really don't like to talk about it. So hundreds of years of literature and nobody's really wanting to own up to exactly what they're going through. But we even know different cultures separated by, you know, hundreds, thousands of years still have this. So it's definitely been around for a long time. And you wonder if maybe full circle, we need to almost get back to manners and the real purpose of those. What a thought.
Marsha, unmute.
Hey, everybody. I'm just going to remind you that we're coming up on
Ooh.
about 6 more minutes. Dr. Webb, several people have been asking if you would carefully say the names of the medications and spell them because they're difficult to catch. So one started with a G or something. I'm not sure if you remember the ones you mentioned.
Started with a Q. Quanfacine.
Dr. Jaffe, do you have that list? I wonder if we could copy paste that.
Yeah.
Because that was the list we went through.
Yep. I will copy and paste it.
Perfect.
The
But
chat.
yeah, an hour goes by quickly. But I guess sort of to your point, in the interest of time, I think the update is it is much easier to talk about this than it was a few years ago. And we're on a really good trajectory. All indicators are in the next couple of years, this will become a commonplace thing that one is allowed to talk about and that schools need to pay attention to, that there's resources to help families understand it better. And I think the idea of that collaborative team approach to solving this problem is not just a nice thing to say, but entirely true. If medications were the magic cure, people would have figured this out by now. There would be a Reddit forum somewhere that would go, hey, by the way, if you take this one thing, it all goes away. That news would have spread within days and we'd know the answer. My experience as a clinician has definitely been that medicines can help, but it takes a surprising amount of dedication and work from the whole team to make it stick and to make it really effective. And that's not just a cute way of trying to say the medicine doesn't work, but I just like to say, if we all try, maybe we'll think it works. There's something curious about human nature and misophonia that most patients I treat despise this thing. They don't like to think about it. It's like trauma. They don't even want it. They don't want to think about it. It's not fun to have to even come to the appointments and deal with it. And it can be exhausting to do treatments that are partially effective. There's something uniquely tiring about that, to say, okay, 50% gains, where you really need to have a supportive team that can even remind you did good. You're better than you were. You're much better than you were. And here's how we can make it even better. Here's how we can integrate that. Here's how we can help your family understand, how we can help you build on the success that you have. So I think that is the answer. Who knows in 10, 20 years what kind of cures we may have. But for now, medications are not magical objects that make things disappear. They're like Advil for a chronic stress headache that may take the symptoms down partially and give you an opening, a better shot at doing the exercises you need to make it get even better.
Yeah, so I'm going to apologize for not putting that into the chat because somehow when I hit whatever button I hit that took me off base, I've lost the bar at the bottom that has the chat button. I don't have it in front of me. Somebody could probably tell me how to find it again, but I don't see it. So we will have.
Dr. Jaffe, I'm using the Q&A. It's at the top of my screen.
I
So
don't have
the
any of those.
questions are in the Q&A.
I'll type some.
I
What
don't have.
if we ask
Okay, Dr. Webb is going
when
to type some in. He's going to type some.
when we post it, I guess we could put it, maybe we can put on our website, on the Facebook page and the organizational website. Maybe we can put the list of things there. I'm
I
sorry,
sent-
everybody, but
Okay, Dr. Webb he did that. He took care of that.
There we go.
okay, well, we have about 2 more minutes. Thank you for coming. The questions were interesting. There were a lot of cases, Dr. Webb, of people wanting specific advice about their own medication cocktail use. And I tried to answer and say that we're not able to provide individual case advice on the internet like this, because actually that's out of the rules for most medical professionals. You're as good as well talking off to your neighbor across the fence on these kinds of settings, but we appreciate the comments, and I know Dr. Webb will read them, no doubt, later and go over them. It's a little hard to do both things. Do either of you have anything to just wrap up with?
I do. I'll go back to Dr. Webb. There's one general question that gets asked often, and it's in here. Misophonia is not in any of the code books. So how do you get a diagnosis, basically? And I think the answer to that is go see somebody who knows what it is and who works with it. And if you need a diagnosis for the purpose of explaining it to the school, then you explain it. If you need a diagnosis for the purpose of submitting an insurance form, then you need to put something else in there. So audiologists have codes that they put in. I often end up using codes for generalized anxiety disorder because I don't think anybody with misophonia doesn't have some anxiety about it. They walked in with it and it causes anxiety. So it's a legitimate diagnosis. So if you have to have a diagnostic code, you use something like that. If you need
it. And I'm going to interrupt you because the audiologists still have the best code. It's abnormal auditory perception. It is a legitimate code that we can use for diagnostic, and it's not just generalized anxiety or something else. So, so far we're still the winners, but unfortunately, most audiologists are not familiar with misophonia. So, you do have to look at our provider list or find somebody who is familiar with misophonia that can understand the situation, because again, there are no objective tests for this disorder. There are no scans, x-rays, brain things we can say, look, there it is. You have to have somebody that understands how to collect the data, case history, and give you an authentic diagnosis, which then can lead to letters of accommodation for work, school, college. You know, we can't write one to your family. That would be a nice letter of accommodation. Someone should come up with that, Dr. Webb.
That would lead to a lot more psychotherapy sessions.
All right.
But-
So in closing, do you have some thoughts, Dr. Webb, you would like to say?
Sure. Yeah, I think we're having careful, deliberative discussions because I'll say this about the other leadership here. This is a group of people that I think values ethics above all else, like in a really unique way, very different from other groups of professionals I've seen that just can't resist coming up with some great product advertisements or ways to advance themselves commercially. And so I think you see a lot of this careful deliberation about how we describe these things. But it's still important to hear that we are much better off than we were a few years ago, because a few years ago, this discussion wasn't happening at all. Everyone was suffering alone and often being told that they had some other problem that wasn't even true. We're light years ahead of where we were. And just the fact that now we're able to start talking about different treatments that are aiming at this disorder, it should bring a lot of hope. The future is going to look much better than the past did. Good, much better days are coming.
Good parting thoughts. I agree with you 100%. So thank you very much, Dr. Webb, for taking the time on a Saturday morning to participate with us and serve the misophonia community. For people who are online and don't maybe know this, this is a volunteer organization. We only have one person who's paid part-time to do some things in the office, but all the rest of us contribute our time because we're concerned about this situation and we want to do the best we can to help people.
Exactly. And please, please, please spread the word about our upcoming fall convention in Atlanta, Georgia, and everybody come if you can. We're going to be identifying that date very soon. There's going to be a great lineup of speakers. We still have Miss Lisa Loeb involved with our organization. She came to Albuquerque and introduced a whole bright new light into their organization with her music and empathy, and her children have misophonia. So we are making some great headway. We have a new team of outreach and convention organizers, and even a person that's going to start writing journal articles for the association. So listen, things are looking good. Things are looking good. Keep the faith and stay strong.
Okay. So thank you all for joining us today. And thank you, Dr. Webb. Many blessings to everybody.
You too.
All right. Someone else is going to have to close this because I don't have that button either. Somebody else.